Okay, and Dean is not on yet, but I texted him, so maybe he'll join us.
Okay.
If
Once
not,
we're ready to.
yep. Okay, we're streaming.
All right. Good evening, everyone. It's 5:07, and I'm going to call to order the Southwest Health System July 29th board meeting. I know some of you are visiting us via YouTube. I don't know what the numbers are. I'm sure there's hundreds out there, and we appreciate all of you from the public joining us, especially during these difficult times. Are there any questions before we jump into the agenda? Are there any questions from anyone joining us on YouTube this evening? Anything in the chat box, Bridget?
Not yet. You might give it just a second. YouTube can have about a, I don't know, 5 or so second delay.
Okay.
I will keep an eye on it and let you know if someone joins us.
Okay. Well, I'm gonna move forward on this agenda. We don't have anyone from MCHD with us yet for a report. If Dean joins us, we'll backtrack. But I'd like to move into the CHC report with Craig Sims. You have the floor.
Thanks, Tom. My information is in your packet. Not a whole lot more to report, except we continue to monitor COVID activity. We've seen in several of the rural markets, a recent surge, and so we continue to follow the guidelines, monitor the PPE, but we've also seen a little recovery, still at a running around about 80% of where volumes were for the most part. Work with Rick and Tony on the funding and the allocations, and continue to monitor what the government is doing in that regard, in regards to payback, or there is some additional conversations going on between the House and the Senate in regards to some additional funding that may become available. So we continue to just focus on that. But really, outside that, Tom, I'll be happy to answer any questions the board may have.
Yeah, I always ask about infrastructure. I know the money that the assistance that we're getting right now is very important for operational, for the operations of the facility. And I know I brought it up with Rick and with you, Craig, over emails. But once we get out of these challenging times, we still face additional challenging times with all the infrastructure needs of the hospital. And I'm sure it's on every lobbyist's radar screen to pursue funding for infrastructure. But I just want to reiterate that I think that that's pretty important to rural hospitals such as South.
No, absolutely. Tom, there are some alternative financing that's been made available out there with, I think I mentioned last time, that we're looking at pretty cheap interest rates on the terms that may be available. There's discussion on the advanced Medicare that either may be forgiven. I don't know if that's going to be likely or not, but will probably, or could be extended on the payback of that. So still a lot of moving parts on that, and the positive recognition that for rural healthcare, they know that they're going to need some additional support. It was recently reported that most of them will operate by the end of the year at a 7% margin loss. Some much more higher than that, but it's still going to have an impact on rural healthcare, no question about it.
I think part of that proposal also, Craig, is that they're talking about possibly lowering the interest rate to 1%.
Yep.
Yeah.
Yep.
Okay.
That's right. So we continue to monitor all those things, see how it comes out, and talk with Tony and Rick about that.
Okay. Craig, anything else on your end?
No, sir.
Okay, and I think Deborah was with us, but are we hearing from her? I'm sorry, never mind, getting ahead of myself. Okay, any questions from the board or anyone else for Craig? Doesn't sound like it. John Brooks, did you join us? All right, let's go ahead and move forward. I think John was going to call in. I think he did. Let me check here. I don't see him, but let's move forward anyway. Okay, Travis, it's all yours.
Thanks, Tom. You should have in your packet the Human Resources Dashboard for July. I'll just preface that with this data when I put it together to get to Bridget so she could get the packet together is as of July 13th. So a little over a week ago. Total number of active employees at that time, 415, broken down full-time 330, 21 part-time, and 64 relief. At that time, we had 35 providers that were integrated into the system, 22 physicians, 6 nurse practitioners, and 7 physician assistants. At that time, we had 10 active contract employees, 6 of those being clinical. So far, year to date, and this is actually as of June 30th, we had separated 53 employees, 34 full-time, 3 part-time, and 16 relief. And then we always talk about turnover. We'll talk about it in a little more detail, but as of June 30th, our turnover rate minus relief employees was 10.4%. And you'll notice I put 17.5 as the national average. So we're on track there. And total work comp incidents so far year to date has been 23, and I have a slide later on with more information about that. Some of the projects, noteworthy things that HR has been working on, continuing with the CHC recommendations, still looking at outsourcing our FMLA processes. Probably the biggest thing in the last week and a half, we initiated this year's version of the engagement survey. So the same survey that we did last year, I think it was in February of 19. And that same survey went out on the 20th of July, went out to all employees as well as providers. As of yesterday, we'd had right around 56% participation on the employee side and about 23% on the provider side. And that survey is open until the 14th of August. NRC, which is our third-party vendor that administers the survey, has indicated they'll have those results available for the board for the August meeting. So looking forward to seeing what that says. Benefits Advisory Council was started this year. Obviously with COVID, that kind of changed a lot of things. We have met a few times. Good multidiscipline team that we developed, have providers on it, have clinical people, non-clinical, just to get some staff perspective in regards to the benefits program. We continue to scan and retain our personnel records electronically, working through that. Obviously have a lot of records, so that's an ongoing project. Just an update on remote workers. When we started doing the remote work with our staff, we initially had 81 employees that were assigned to work remotely. 3 of those have separated since then. 43 of those have returned to fully being on site at the hospital. 29 of those still partially work off-site, so they're splitting their time between on-site and off-site, and we have a total of 6 that remain fully remote at this time. This actually on the 12th of July, the second half of the COLA increases. As you remember, we budgeted for a 3% COLA for staff for this year. They received half of that in January. The other half went into effect on July 12th. So those employees will see that on their paycheck this coming Friday. Let's see, Senate Bill 20-205 went into effect a couple weeks ago. well, it was passed a couple of weeks ago. It actually goes into effect on January 1st, 2021. And that's paid sick leave for all employees. Something new for us is that we'll have to include our relief and PRN employees for those requirements. It does cap out at 48 hours. And basically the rule around it is that you must accrue 1 hour of sick leave for every 30 hours worked. And it can be administered in a lump sum. So we're going to look at how to implement that in order to comply with that new legislation. And as far as education, Clinical Exchange is up and running, which is an excellent tool that's tracking and managing our student compliance and their placement as well as their scheduling. And then we did hire a part-time education coordinator. As you know, Megan Higman was in that position. She's now the inpatient director. She's still involved in education. So we hired a part-time in order to assist with some of the more administrative tasks to take off of her plate. And that person starts next week. The next few slides are the dashboard typically share with you during these reports. So the first one is a workforce overview. Probably the main thing as you look through these slides, when it says head count, for example, this says 426, doesn't match the numbers I gave you at the beginning. That's potentially, because we had 415, that 426 also includes any contract people. So for example, Tony, Karen, Rick are part of that number. Any travelers that we have at that time are part of that number. And then if the turnover rate on these slides also includes PRN people. So we typically, when we report, we exclude the PRN if they're an as needed employee. So these turnover rates are going to be a little higher, but as you'll see in a couple slides here, we're actually well below the national average. Let's see, the next slide is headcount trends. Just gives you, and this is from July of 16 to July of 2020. So it kind of shows you active employees over those 4 years, what that looks like. The turnover rate, obviously with 2018 being the high rate when we did the reduction in force. Just some information that's interesting to see. Let's see, the next slide is the graph that I keep track of. So the 2020 employee count, you can see as of June, we're exactly where we started the year with total employees. We have 4 more full-time than we had at January, and the PRN, full-time and part-time, I should say. And then the PRN down at the bottom, 73. We started the year with 63. The next slide, which just at the top, it shows, well, on the left side, it shows a spreadsheet going back from January 1st of 2018 until July 13th of 2020 at the bottom. It's interesting data in that, you know, we have 46 less employees as of July 13th than we had on January 1st of 2018. So down 11%. Actually 61 less full-time than at that point in time. 5 more part-time and 10 more relief. Hired since we did the reduction in force in September of 18. We've hired 139 full-time, 7 part-time, 73 relief, 13 providers, which is pretty amazing. 96 out of that total number, 96 have been clinical, or 44%, 123 or 56% non-clinical. During that same period from January of 18 to July 13th of 20, separated 169, and you can see those statistics there. On the next page, those 46 less employees than there were on 1/1 of 18, or 61 full-time, 18.48%. Our average wage, and this was as of July 13th, is $55,000 a year. Our medical coverage averages out at about 15.4%, or $10,671 a year. FICA benefits are typically around 10.95%. So the total average per employee, and this obviously does not include providers, is $71,700 per year. So with 61 less full-time, that's a savings about $4.4 million. And then rehired reduction in force employees, we did rehire 17 of those after the reduction in force, which is about 42.5%. So we did try to bring back the best. All right, on the turnover insights page that shows the 14.3% at the top, annualized rate of 24.5%. If you look down below the bar graphs at the top there, I can't read my copy. It says the sector benchmark 26.4. So that's Paylocity data for any of their clients that are hospitals. So as you can see, we're about 2% below the benchmark or the average of their other clients that are hospitals. And that number, interestingly, I looked at it this morning. That number is actually up pushing 50% as of today. So obviously a lot of hospitals struggling with turnover, probably due to layoffs and furloughs that fortunately we haven't had to participate.
Hey, Travis,
Yes.
I am trying to share the page of the screen that you're on, and I got lost.
Way down too far. Scroll
Okay.
up.
I should have a page number there.
It's page 10. Tom, can you hear me?
Yes, I can hear you. It is page 10, you're right.
Yep. Okay, I'm back on.
Yes, that's the page, Bridget. That sector benchmark and subsector benchmark, those are from, as I was saying, those are the hospital clients through Paylocity. So, our annualized average of turnover is below those benchmarks, which is good. And as I was mentioning, looking at that number today, it's actually pushing 50% for those benchmarks. So, and probably due to layoffs and furloughs. Go ahead and go to the next page, Bridget. So on the 2020 turnover, just showing you how we've progressed throughout this year. Not a real steep climb. It's showing that we're going to end up above 20%. I don't believe that we will. I foresee July is probably going to, our percentage is not going to raise very much. So pretty flat line. And then down below that is just a comparison for the last 4 years from 16 through this year of what those percentages of turnover has been. Obviously with 18 being the highest. Next page. So the labor cost trends, again, this was as of July 13th. We did just finish another payroll, so that July number, and again, I looked at it today, it's almost right in line, and Rick could confirm with the June. Might be a little bit higher, but that just showing you that for the period of January of 2020 through July of 2020, As of July 13th, 17 million in labor costs, 350,000 labor hours. So just interesting information. If you scroll down a little bit more, Bridget shows you where it's a breakdown, and it just showing you the top 5, I believe, of where that labor cost is spent. Obviously, primary care and women's health, that's where the majority of our providers are employed, same as specialty ER physicians. So. And then down at the bottom of that page, just some different breakdowns as far as how that money is broken out, whether regular, meaning just typical salaries, wages, overtime, bonuses paid, and then any other things. Next page. Almost done here. So the labor cost overtime trends, same time period, January of 2020 through July 13th, 315,000 in overtime costs, 8.6 thousand hours of overtime. It does show you that overtime's trend, obviously through the COVID and remote work and trying to minimize overtime as much as possible. I think we did a good job of that decreasing as we went. And then the bottom also shows you the top 5 spends in overtime. Ambulance is always going to be on this list, probably as the top, just because of the nature of the way they're scheduled. They basically are scheduled for overtime because of the nature of their job. And then the final page just does show you the work comp, and this is on a rolling calendar. So the first half, January through July, as of July 13th, is for this year. August through December is for last year. You can see not a real, I don't know that there's any real way to predict work comp. The 10 in January probably had a lot to do with exposures instead of trips and falls, which is somewhat unusual. And those exposures, you know, could be somebody getting spit at or blood splattered or anything of that nature. So that's the work comp. And that's my presentation, pending any questions from the board.
I don't have any. Thanks for explaining what exposure was. I wasn't sure whether that was COVID related or what have you, but.
No, and that's a good question, Tom, because COVID, and that's been a matter of debate within CHA and within politics in general. Actually, COVID is not considered a work comp incident at this point. I think it will become that eventually, but as of right now, we haven't had any work comp claims that are COVID related.
Well, I think that speaks well of the protection program you have going on, the PPE program. And I was reading the other day how difficult it is to prove a workplace exposure to COVID. So kudos to the infection control staff or whoever handles that. Any questions from the board? Okay.
Nope, Ben.
Anything, Bridget, did anything come in on YouTube?
Not that I see.
Okay, good. All right, let's move on to Karen.
Hi, good evening, everyone. The first few slides I wanted to share with you are HCAP scores. So we went with NRC in Q4 of 2019. It's a new company that's providing those surveys to our discharged inpatients. And you can see in 2019 that we had about 30 surveys returned. We really want to be closer to 60. And that was their first quarter to do it. So, you know, I could understand that. And then first quarter of 2020, we came very close. They did have a breach during that time. So there was about a 4-week period they were not sending out surveys. And typically you have to survey your patient within 45 days of discharge. So that did limit us a little bit. Now, what you see on 2020 is only the first month of quarter 2. That quarter will probably close out toward the end of August when they get the rest of the results. Now, one of the things with NRC is they mail the survey out versus calling. So typically CMS will auto adjust, because typically when you send them out by email, then you are going to get probably a little bit lower score is what CMS says, because when you talk to a real person, people won't tend to complain as much. They will auto adjust that for us. And so really this is just giving you trends from the dimensions. Now you see it says CCAPS or CAPS dimensions. Under each of those dimensions is typically 2 to 3 questions that the patient will ask. Then you can see there's a pickers dimension. Those are questions or domains or dimensions that we could ask the patient in addition to the ones that are required by CMS, which are your top dimension. Bridget, if you want to go to the next page. I like the way this next one shows, because it kind of trends it out to see quarter by quarter, how are we trending either up or down. And you can see that most of the quarters we are trending up, a little bit off on, let's see, I think it was communication with nurses. We drop a little bit, which is interesting because typically the communication with doctors and nurses almost mirrors itself. I don't see that trend so much here. So we are going to work on that piece as well. So we have selected a new board for the patient's rooms, which will help with the communication. We should be getting in samples very soon. The nurses kind of went through all these different ones and decided what they would like to put in the rooms. So they'll provide a more communication between the nursing and the patient than just the whiteboards we have, which are really just blank boards at this time. So one of the things that we've been working on prior to COVID, but was communication about meds. And you can see that's the, and you can see even through COVID, we've done really well at communicating those medications with patients, which really is talking about, did you understand the new meds that you were taking and what the symptoms could be from taking those new meds? So a lot of good work around that. If you go to the next slide, so the next slide is I find it's just a very interesting, oh, sorry, got one more. These are your CAPS dimensions. And then the next slide is your picker dimensions. So that's the questions that we were able to choose through NRC to ask our patients. So the next slide, I think it just gives you a real good viewpoint to compare us to other people. So if you want to go to that next one, Bridget, I think it's page 19. So this next one really is able to compare us to CMS as well as the state. So you can see the orange line is the state's high and low scores. And then the green triangle at the top is the CMS average. And then of course the black line is the state's average. The blue triangle on the bottom is us. So you can really compare us to what you see the other people in the state are doing, as well as CMS. And so the facility score, which is the one next to the blue dot, is your actual score, your percentage number. And then of course the score right before it in the blue bubble is your percentile ranking on the national level. And so it just gives you a kind of a picture of what would we like to work on, which we know communication with nurses is one thing we would like to work on, as well as the care transition. Now the overall rating of the hospital, remember, you have to have a top box number. So the overall rating, to get a point for that, the patient has to answer 9 or 10, which that means they're extremely happy with the services. If you answered 7 or 8, of course, we don't get a rank for that. But those patients aren't typically happy or unhappy. They're just kind of neutral. And then of course, if people are rating us below a 7, then those are the people that you really know are out in the community. complaining about the services they receive. The would you recommend is typically your confidence scores. And you can see that the scores above don't really correlate with the overall rating and the would you recommend. So those are some things that we'll be working on as well. So I think that concludes the HCAPS. Does anybody have any questions?
I don't have any. Anyone else on the board?
I have a comment that this was one of the most helpful slides I saw. I
Good.
really enjoyed reading the slide, and I think it provided a lot of information. So kudos.
Great. Good, thank you. So I have 2 more slides to share with you. The next slide is our quality events reporting. So when people have an event that they want to report or a near miss, they'll put it into our ComplyTrack system. And this is just some of the raw data that we've been able to pull out. So on a weekly basis, we review these from the quality risk section just to say where we're at. We also score the event according to ASHRM, which is your risk management governing body. And you can either be a pre-patient event or you can score it as a 1 through 5. So 5 means there really was no harm done, and of course 1 is the most severe harm. But this slide itself just talks about how many events were reported by month per department, just for the quality, that this doesn't count HIPAA or patient complaints. So what we'd really like to do is make sure that we're getting those numbers up, because we really want to catch those precursor events so that we can improve our process before they actually become an event. And then Bridget, if you can share my screen, if you'll allow me to share my screen, I've got one more slide to show.
Yeah, give me 1 second. I'm not as
Sure.
good on more.
So one of the things we do is, I know last month we shared the CHC report. And so that's a generalized overview of all the clinical areas. And so what Lisa and I have done is gone through and we've broke it out to actually 3 more pages of clinical data that we're really looking at. And we wanted to be able to share some of those pages with you on a month-to-month basis. All right.
You seeing that?
I think I've got it. Can you see that?
Yes, we are.
All right. So this is one of the pages, and we cover this in our patient safety, environment of care meetings, and then that goes up to the QIC. And so the first one is, of course, visits from regulatory agencies, and we had none this year. October to December was from DNV. They did come for their mid-year, and January through March, I, to be honest, don't remember what that one was. I'll have to ask Lisa on that. Then medication use, we look at adverse drug events, and typically we want the data in by July 10th for that, but we've been having some trouble running some of our reports, so we'll be able to share that with you next time. So if you go on to surgeries, this just shows that some of the things that we're looking at. So it shows you the total number of inpatient and outpatient surgeries, as well as the H&P completed within 24 hours and updated, informed consent completed, readmissions. So we don't want readmissions following a surgical procedures. Unplanned returns to the OR. You can see we had 1 in third quarter of last year. Surgical site infection. We did have 1 surgical site infection, and I think that we have not had 1 prior to this for the last 5 years. So we did review that case and did not find any fallouts from our processes that caused that. And then of course, we're looking at intraoperative deaths. Also, one of the things that we look at that is a real big review that we need to do and be able to share with our regulatory bodies is non-invasive procedures. So this is really using sedation outside of the OR. Typically you see that used in the ED, sometimes maybe in OB. And so we have specific things that we want to look at. One of the things we implemented at the first of this year is we're doing 100% chart reviews on all of those. And if a nurse has missed some of the documentation, they get a little form that's sent back to them and they have to correct their documentation. And what we're really looking for is to train people to make sure they're doing it correctly. And then if they continue to have a trend, then, you know, the conversation becomes a little bit different. And of course, we do not want adverse outcomes. So that's why you see 0 to 13, 0 to 6. And then the other thing we look for is, do we have to use a reversal agent, which would indicate that we've given too much medication. You can see we have not given too much medication that needed to be reversed. Then we move down to deliveries. We also look at the total number of primary C-sections. That means it's the first time that a mom's had a C-section, as well as the total number of C-sections. And then we look at the C-section rates. That's just a few of the obstetrics. There's a lot of obstetrical metrics that we look at as well. And then of course the ED, total visits, as well as level 1 trauma activations. A couple of things that ED, well, actually, we're looking at 4 different things specifically. Stroke to CT time. We're actually meeting, I believe, next week to talk about how we can get the patient right from the ambulance into the CT before they even get into the ED, because you really want to know what that looks like. We're looking at STEMIs as well, and admission, the decision to admit to the admit time, we're looking at that. And then, of course, 72-hour returns to the ED. Behavioral restraints is another thing that carries a high weight of risk, and documentation has to be very spot on. So we're doing that same format that we review every chart that had a restraint and make sure that it's 100% accurate. And you can see we are at 85.14%. So there's a lot of components that you have to document, and if you miss one, then it's a complete fallout. So we are working with that as well. And you can see we have a low number of restraints for that. So that's all on that one. Any questions? All right.
Is it unusual to have restraints in similar sized hospitals, that number of restraints?
Usually for small hospitals, you won't see a whole lot. There's 2 types of restraints. There's medical and behavioral. You'll see more medical for us, which just means that typically if somebody's intubated, they'll have a restraint. We do see occasional restraints in the ED, although we have really tried to limit that. And I could look at the numbers from last year, but our rates from last year to this year have really dropped as far as behavioral restraints, which that was our intent. So we did change our process on that. All right, thank you.
Okay, any other questions for Karen from the board? Okay, let's move on to Rick. You'll have to mute.
Yeah.
Unmute.
Yeah, thank you. Yeah, Karen's a hard act to follow. So kind of go into the financial narrative. Again, strong cash collections, patient cash collections of about $4.2 million in June. We did decrease some operating cash by about $1.2 million. And that's just, paying our AP, any kind of credit balances, things like that. And then working towards, some of the, the payments that we have to make for some of the assets that we bought that we're bringing on board and new equipment, things like that. Our combined investments gained about $50,000, and that's due to a market rebound. We did have strong volumes, so we had about 90% of volumes in most of our departments. So that kind of came back. So that led to our gross AR increasing of about $1.1 million, and our net AR increased about $400,000. Again, inventory decreased slightly by about $4,000. And a lot of that's based on usage and us just making sure our patients and our staff is safe with the PPE or protective personal equipment. Fixed assets, again, increased by about $181,000. Again, we talked about some new assets that came on board for us in terms of lab equipment or other things like that. We did pay down a significant amount of our accounts payable. So we decreased accounts payable by about slightly over $500,000. Payroll liabilities did increase slightly by $121,000. And July we normally have 2 months where we have 3 paychecks, 3 payroll Fridays. So we've gotten prepared for that for the month of July. Again, we did see some cost report receivable increase, reopening a 2013 cost report. And we did see some stimulus money come in. So we went ahead and reserved that as unrecognized revenue. We really had a strong month. Revenue over expense was $6,000, brought our year-to-date total up to 1.2 million, and our earnings before interest, depreciation, amortization was slightly under $500,000, and it brought our year-to-date EBITDA up to about 4.2 million. On our income statement, again, we missed budget for gross patient revenue, but again, we were close to 90% in all departments. Net patient revenue also decreased by about 423,000. Clinic revenues, again, they were only down by about 89,000. And I think a lot of folks are coming back into the clinic, either physically or in some kind of telemedicine approach. Our salaries were in line with budget or lower than budget. Providers were below by 64,000, and staff was below by about 66,000. Contract labor again fell below budget, and like Travis said, that includes Tony, Karen, me, and some of the travelers that are working. I believe we have 3 travelers, 2 nurses, and a lab tech. Medical specialist fees were in line. Purchase services was up some. That was due to the IT migration from the Market Street Annex back to a server room located on the first floor. Supplies, they were only above budget by about $30,000, and a lot of that relates to PPE that we're purchasing. Everything was in line. Interest expense was dead on the amortization schedule. Depreciation was slightly under budget, about $364,000. The sales tax donation was $125,000. So that is the MCHD portion that covers our debt payments. Basically, the narrative is derived from the next couple of pages. Page 24 in your handout PDF, page 6 if you're using the financial statement packet. There's your income statement, and then our balance sheet with variance columns out to the side.
Rick, quick question. That 125,000 from MCHD is actually not terribly low, correct?
No, it's based on sales tax. That's the sales tax that was passed to help us cover the debt. And again, so there's still a lot of people that are shopping Montezuma County. So when COVID hit, we were anticipating a fairly big fall off, but it hadn't been that bad. It's it's been in April 108,000, May 112, and June $124,000. So it's been pretty strong.
Yeah, I think it's important for those who aren't always joining us on the finance calls to understand that we're not in the hole, at least from that perspective, that we thought maybe.
Rick, what was it last year?
Dan, I'll have to get that number for you, and basically we can pull that last year's packet. But it seems to me it ran maybe somewhere around 135 or 40,000.
So it's not that much lower.
Maybe $10,000 to $15,000, and that's a best guess. We can give me some time, and I can answer that when Tony and Jeremy are doing some of their other reports. I'll go back and I'll find this schedule in one of our previous bond packets, but I mean we're not down much at all.
Okay, Rick, wouldn't it just be the last year? Wasn't it 122,000 this month?
I just need to go find the schedule. I think so, but it could be. Yeah, that's a good point. It should be on the income statement. But I didn't know if Dan was looking. I didn't know if Dan was looking for how long. I guess cumulatively. it may have dropped off. I know we have some other things in donations. So some of the other things we have in donations relate to the RTU contribution. And then we did receive like some SHIP grants and Next 50s. So if I can find the schedule that looks like this one, I can give you an accurate number of what the sales tax donation was, if that makes sense.
All right, didn't mean
Hey,
to.
Rick, this is
Sure.
John. If you'll just go back fourth quarter and third quarter last year and pull up the schedule.
Yeah,
that
John, that's what I'm
we
doing.
provided, yeah, that'll give you the whole year on that schedule. And I think Tony's right. I think it's in this 122 to 125 run. Because it all comes out to roughly $1.4 million by the time the year ends up. Last year was $1.460 or something.
Actually, that's the guarantee. Their guarantee, the MCHD guarantee is $1.4 million, but
Right.
when the marijuana legalization passed, that's kind of added to the excess sales tax, and we did see a true-up payment last year. A couple of true-up payments with that marijuana sales tax.
Thanks, Rick. I didn't mean to send you down a
That's all right.
rabbit.
Yeah, sorry.
That's okay. No worries. But yeah, I'll find that schedule. I'll find that schedule and basically send it out to you guys. Looking at where we were and where we are. Like I said, the MCHD debt schedule. So I'm on page 27 or 9 if you're looking at in the finance packet. So we finished a little bit over 112 days cash on hand for the month of June, and right now we're projecting July. We're projecting somewhere around 104 days. So again, and even with 3 payrolls, that it hasn't, cash is still fairly strong. The statistics, again, if y'all have any questions on that, that's on page 10 of the finance report and page 28 of the packet. And then you look at the next page, which is page 11 or 29. You look at, these are our ratios that are set for our forbearance covenants that we've got to achieve in terms of return on assets, days cash on hand, our acid test ratios, and so forth. And we're basically, we're hitting these metrics. Didn't know if y'all had any questions about that. Our sources and uses of cash, again, that's just cash flow showing what we did on a basically from where the cash came and how we used it. And then basically we're grading our metrics on the next page. Again, page 31 in your overall packet, or page 13 in the finance report. And this is how we're graded about how we're managing AR. So we're our rolling 12-month cash collection year-to-date percentage is 113.5%. It won't be that much for the hospital. It won't stay that way. Our projections is we're going to finish somewhere around 105%. That's our guidance. Our AR days, we're within that metric. Medicare, Medicaid, working through the commercial. We've got some things out on appeals. That's what's hurting that metric. So we write things off when we exhaust the appeals with insurance companies. Our credit balances, we're addressing those as well. And, our clinics, again, we're a little bit behind, but that's some of the new providers. As Travis said, we brought in about 13 new providers, and I think we probably brought in about 5 this year, and it's just credentialing them on plans. And that's basically, guys, all I have. I do know that at some point, John, you guys are going to ask him to approve the ratios in the finance committee. But unless y'all have any other questions, That's my complete report.
I have nothing. Anyone else? Okay, we do have some recommendations from the Finance Committee. Let's see, we did discuss the second quarter ratios as well during Finance. So we have 3 motions that we need to approve. Do I hear a motion to approve June financials, June 20 financials?
I so move.
Is there a second?
Second.
Okay, all those in favor?
Aye.
Aye. Any
Aye.
opposed? No. Okay. Do I hear a motion to approve the second quarter ratios as recommended by the Finance Committee?
I so move.
Okay, Dan made the motion. Is there a second?
A second.
Shirley second. All those in favor?
Aye.
Aye. Aye.
And finally, do I hear a motion to approve the CHC invoice as recommended by the Finance Committee last Thursday?
I so move.
I second.
Is there a second? All those in favor?
Aye.
Aye.
All right. Carrie, you're up next.
I would.
Thanks, Rick. Thanks, Rick.
Hey, you're welcome.
Thanks.
Hey, Tom,
You.
I will have a number for you after Carrie's report.
Okay.
Thank you, Tom.
No
Thank
sweat.
you.
All yours, Carrie. And you're
Thank
muted.
you.
There you go.
So really the only things that I want to talk about tonight with everyone is recruitment. The first part of recruitment is the wound care clinic. Wendy Stevens is an NP who will be transitioning the wound clinic from Jody Harris on the hospital side to the rural health clinic. That will take place August 24th. She will start, so I'm assuming the wound clinic transition will take place likely the first week of September. Second big good news for recruitment is general surgery. Dr. Cynthia Millward is a general surgeon from Montrose. She has accepted an LOI, letter of intent, that we have given her, and is looking to join our team in November to replace Lori Medina, who will be leaving in September. So we were really concerned about having a gap there with general surgery and providing that service to the community, but we were really lucky, and our candidate accepted our LOI this week. So that's a huge step forward in general surgery. We are still, the only lack that we have in the clinic right now, or deficit, is an OBGYN. So we are continuing to recruit for an OBGYN. Again, I think I've said this before, but we're being extremely, we're vetting everyone extremely well. And so we did have a lot of candidates towards the beginning and resumes to review, but they didn't meet the criteria that we wanted for this community, which is rural health experience, a desire and knowledge about the Cortez and surrounding areas, a desire to live here, and not be locums or traveler or a short-term assignment. We're definitely looking for someone long-term to partner with Dr. Schmidt. And so that, and Dr. Camia Smith, and that search is ongoing. So that's my main focus for the next couple of months, is to really vet some more candidates. We have teamed up with Jackson Recruiting, so I'm hoping that will help us to bring some more qualified candidates and those that are familiar with our area and rural medicine. Those are the main recruitment updates. We do have an FPOB, which if you're not familiar, that's a family practice doctor who has gone back and completed a residency in obstetrics. And so they are able to do C-sections. She is coming to visit us for an on-site tour on August 13th. Sorry, I had to think really quick. 13th, 14th, 15th. She will be here to check out the area, get an understanding of what our setup looks like with Dr. Smith and Dr. Schmidt, and potentially be another resource for us. The benefit of having an FPOB in addition to recruiting that OBGYN is an FPOB can see pediatrics. And so anyone that has looked at our financials and our call schedule understands that we are extremely stressed for pediatrics as well as OB section call. Just knowing the transition of providers and what that looks like over the next 5 years, we really need to lock down a good recruitment plan. And so we are looking at all types of candidates, including FPOBs. So excited to have Cassia Bastrek join us on the 13th, and I'll provide an update at the next board meeting as to how that visit went. The other update that I have is Mancus Clinic did go back to Mancus and has been seeing patients and telehealth patients pretty regularly. As far as volume wise, they have seen 80% of their volume pre-COVID. So not in person necessarily, but telehealth and in-person visits. We're back to about 80% capacity, which I didn't expect us to bounce back so quickly, but those providers out there have been working really hard to capture their patients, reach out to their patients that weren't able to travel to Cortez or can't do telemedicine, and get them in to be seen. So working very diligently with that, as well as providing many upgrades to that Mancus Clinic as we transition in the next couple of months. So excited to move forward there. The other last piece that I would like to talk about with the board is we have hired some what we are calling concierge positions. These positions are PRN, so they don't affect our full-time status, but these are the people that will be screening the front doors of the facility. So we have 3 entrances currently that the patients and visitors can enter through. The first entrance is the MOB, which is the clinic entrance. Second entrance is the hospital lobby entrance, and the third entrance is the ER entrance. And so we do have somebody at those 3 entrances most of the time. They are there all the time at the lobby and the Mancus Clinic, and they are, we do have somebody there until I believe 10 or 11 o'clock at night, most nights and on weekends at the ER entrance. So we have hired for those positions. Those positions generated about 42 applicants for 6 positions, which I thought was pretty awesome for our community. So I think we're going to provide some relief to those that are out of work in our community, as well as help with screening. That position will be responsible for doing the typical screening for COVID. So fever, we'll be taking temperatures at the front door continuously as we have, as well as asking the questions about COVID symptoms and exposure to COVID, and then also making sure that anyone entering the building is following the visitor and mask policy. So wearing a mask at all times when in the building, and then number 2 is having 1 designated visitor per patient. And so we have had great success with the people from our organization who have been manning those positions. However, they are back to a lot, almost full capacity as far as seeing patients. And so that's why we had to kind of proceed forward and look at people to fill those positions. I personally have vetted those positions with Chris Alvarez, the Director of Patient Access, and Monica Kennedy, the Director of Clinical Operations. So I sat in on all those interviews, and simply for the reason that they are the first person that any patient, new patient, returning patient, visitor will experience at this hospital system. So I wanted to make sure that we had people who wanted to be in this position, who were had a personality that was consistent with our mission. And so I think that we've done a really great job at screening these candidates, and I'm actually really happy to bring them on board in the next couple of weeks. So that's the last update that I have, but I'm open to any questions that anyone has.
Carrie, do you see a trend after we get through all this COVID weirdness and challenges? Do you foresee a trend of telemedicine in small rural clinics like Mancus being something that we are going to embrace even more so? I mean, telemedicine obviously has been around for a while, but what are we learning from it?
Yeah, I definitely see, and really honestly, I should probably let everyone know and reiterate that we're trying to see about 30% of our total patient load in the clinics. We don't want to overwhelm waiting rooms. We don't want to have that. So we really are pushing our patients and the community to use telemedicine until we do have an idea of what COVID looks like in the near future. As far as trending further on into the future, I don't see that this will ever go away. And for two reasons. One, because it's given the flexibility of the patients that, travel a lot. This is a very outdoor friendly area. And so we have people traveling that live here half a year from Arizona, Texas, New Mexico, and they're consistently using our emergency services, so walk-in clinic and ER, and then they're transitioning their care, or they're using our clinics, and then they're transitioning their care to their primary care provider in the other state, and then there's kind of a gap in care. And so we are hoping, and what we've done with a lot of these patients that are living in between areas, is we're having the conversation about telehealth and telling them how important it is to have that continuum of care with your provider. So hoping that if somebody establishes with an internal medicine provider here, has multiple comorbidities or chronic diseases that are managed well for 6 months out of the year, and then they leave the state and then they come back 6 months later and we're trying to get them back on track, that they actually can check in with their provider via telehealth and have those labs ordered, have those radiology studies ordered, and do a general checkup in between and allow that continuum of care. So I think that will be one group that will definitely stay with telehealth. I also see that the patients that have a hard time getting a ride to clinic appointments, and that is a good majority of our elderly population who are using MoCo, and right now in the time of COVID don't want to come out of their home in a way that would expose them in a clinic setting. And so I do think that will, now that that population has started to understand that telehealth can provide them, via video, conference call, all of those things can provide a full visit without a physical examination to hold you over until your next in-person visit. So I do see that we'll continue to utilize it, and I hope that we will continue to work on platforms. We have our Provider Leadership Council has asked the Information Services Department to provide us with an example of 3 platforms so that we can have consistency in telehealth and the ability to do video conferencing. And so we have kind of made do with what we have right now, but we are looking at a long-term plan of how that will work so that every provider can provide the same type of telehealth visit to the community in the future.
Yeah, Tom, this is Craig. The genie really is out of the bottle from the standpoint that, to Carrie's points, first of all, from a technology, a comfort with the patient interaction with physician or providers has been very well received. Most importantly as well is the funding for telehealth. And your state was, I think, one of the first, if not the first, to approve continued funding for Medicaid and Medicare, Medicaid and managed care patients. CMS is looking at Medicare and continuing funding of that. And again, all indications that they will provide additional funding for telehealth because it's growing, and we've seen it very popular in a lot of our rural markets, and it's only continuing to grow.
Yep, I would agree. As long as the resource for our providers is there, as well as the funding to provide us that stability, we will absolutely be looking to utilize telehealth.
I have a quick question,
Sure.
and I'm sure it's not new, but when you're talking telemarketing, I mean, the normal human procrastinates about going to the doctor till it's sometimes too late. And I know that doctors also can see things that patients don't see, like clamminess or coloration. I assume that there's a heightened risk for the hospital in doing telemarketing for those type of patients that wait too long or that can't actually be determined because I mean, I even go to the doctor and I always feel better the day I have my appointment than the day I made it. And I don't know why that is.
That's a great phenomenon I'd like to figure out myself. So I understand, I hear what you're saying, that there is the physical assessment component. And that definitely is a concern. That's likely, I mean, that's part of the whole first phone call. So if you're having a phone call with a patient and they're saying, hey, I'm just not feeling good. I'm not sure why. I'm not sure what that looks like. I'm not sure why I don't feel well. And honestly, we have a lot of patients that do come to us who aren't sure of what their symptoms are, believe it or not. And so those are the patients that we are wanting to see in person. And so we will have that first touch base call and we will transition them to an on-campus visit if needed immediately. So we definitely are fielding those calls appropriately. The MAs have a first initial call. So the medical assistant that is with the provider has an initial call, goes over all the medications with the patient. Are there any changes in how you're feeling? What is bringing you in today? What is bringing this phone call to happen? And then do we need to use video? And so we have actually had great success with people saying, you know, I have this bruise on my leg that won't go away. Okay, let's get on video and take a look at it, and assessing it via that way as well. So we're not only typically having phone calls, but if there's any question, the providers are definitely offering them an in-person visit. And so I can appreciate that, because I think it's important to note that we do want to see those that want to be seen in person, and we do want to see those that need to be seen in person.
Is there also a shortened time frame from that phone call to an actual appointment? Because that can be quite a lengthy duration.
Yes, so we do have what's called acute care visits. So if somebody, for example, a provider is blocked out a certain amount, every provider for primary care is blocked out a certain amount of times per day for an acute care visit. So that's somebody that calls the same day or needs to be seen the same day. So the idea is that maybe Dr. Smith has the phone call with the patient and is concerned, you know, I just didn't like the way she sounded. I looked at her leg, it looked more swollen via video. I really need her to be seen, but I don't have any openings. They will transition that patient to another provider to be seen that day. And if there is not another provider, we'll do a warm, what we call a warm transfer to the walk-in clinic so that patient can be seen.
Okay, thank you.
Sure, absolutely. It's a great question.
Karen, could I ask you a question about the COVID testing?
Yes, absolutely.
We have two types now. I guess the fast one and then the one we send away, correct?
We actually have three types. So
3 types?
Yeah, we have the fast, what we call the Abbott testing, which is the instantaneous testing. We're using that less right now because they have, if you're not symptomatic, it doesn't have a good, I guess, a receptor to pick that up. And so they have been finding some negatives that are actually positives with that in research. And so we're using that less, but we do have the BD Max, which gives you a result within 24 hours. So that's kind of what we're using for our quote rapid testing right now. And then there is the PCR testing that we're using out at the drive-through, as well as the counties using at their free days.
What's the turnaround rate on that?
Well, honestly, the turnaround rate for the first 2 months was probably 7 days, and then it went down to about 1 to 2 days for a good amount of time. And then I would say, and Karen, you can speak to this too, I would say in the last 3 weeks, we have seen an increase of up to 14 days for that result to come back.
Is there any price difference between those tests?
No, it's about supply and demand. So the idea is, and honestly, I think we're all preparing for schools to open, for flu season to come. And so we'd like to use the send away test because we do have more of those on hand. If it's not critical to decision making or critical to quarantining. So if it's not somebody that we're concerned is going to go out into the community and spread it, or if it's not somebody who needs it for their care or their surgery, we're trying not to use the BD Max, which is that up to 24 hours. Now, and then we will ask them to use the PCR, which can, has taken up to 14 days to come back. That's not a guarantee, I'm sure you've seen that Governor Polis just said, I believe yesterday, that he will be pushing on testing at CDPHE to make sure that we are meeting testing needs, because all of those private labs that we were sending to, like Quest Diagnostics, out of CDPHE are taking that 14 days. So I'm hoping that we'll see a swing of the pendulum back to like the 3-5 day mark versus what we're seeing in the last couple weeks.
Just so I understand, Carrie, that that's happening at a state level, not at a national level.
Correct.
But these commercial labs, are they in Colorado? And
no, they're California and Kansas, I believe. And Karen, correct me if I'm wrong. Is that right? California,
Yes.
Kansas, and I believe there was one in Texas that Toyac used. But it is just that they're not in Colorado. So that is part of the concern, but honestly, the private sector was getting us faster results in the beginning, which is why we went to private sector. And then now that Governor Polis has agreed to put some more funding in and to create a faster turnaround in state testing, now we're starting to transition some of those tests back to the state to see what that looks like as far as turnaround time to evaluate where we need to go with those tests.
And CDPHE has the same type of equipment that a private lab would have?
Yep,
for
absolutely.
Testing. And these private labs are just inundated by just massive amounts of testing. That's part of the issue there.
That's what we're hearing, is that it's just, the increase in the amount of testing kits that became available on the market because people started producing the ability to test, and then didn't think about the results. And so we started kind of doing a lot of testing and not working with how we were resulting. And so I think that's where we ended up with that gap. And so that's where we've seen in the last 3 weeks that kind of backlog. And we're hoping obviously to see that pendulum switch back now that we've been told that we would receive additional funding for the CDPHE lab.
That certainly leaves sort of a helpless feeling in many people's minds. I know. I mean, obviously it's under your control, and it's good to see that at a state level we have that type of reaction. And I'm curious if New Mexico and Arizona are reacting and moving as quickly or in that same path. Obviously,
yeah,
our needs.
Sorry.
No, go.
I think that we are, in the meantime, while that's happening with the longer turnaround send out testing, we are trying to secure more of the BD Max test kits so that we will be able to provide more testing, faster turnaround. And Karen, myself, and a lot of the people that are, well, all the people on senior leadership and a lot of the directors in the hospital meet every week as a COVID group. And we have been watching that, including the lab director, and then also working on what that will look like going forward as far as what kind of capacity do we have when schools open. When there are things like, the larger events that are happening in town, the baseball tournament, the concert that they had, and now the county fair. Those can all affect, obviously, the number of cases. And so we want to be able to test when it's really important to test. And we need that fast turnaround. And so we are kind of, and I don't want to say saving, but we are allocating a certain amount of tests for knowing what increased gatherings will create more symptomatic people. Dan, did I answer your question?
Thank you.
Okay, good.
Is that all, Carrie?
That is it. Yep. Unless you have any more questions.
No, that's no, great update. I appreciate that. Does the board have any more questions? Doesn't sound like it. Okay. Thank you, Carrie, and thank all your people for working so hard. I appreciate it.
Thank you.
Tony.
Sure, just a couple things. And while we were talking about COVID, I'll just share with you. I've been working with the county and the city, Mancos, Dolores, everybody working on a committee that's exploring the possibility to, if you know how the current governor's current order works, unless you apply for a variance from the state, you continue under the safer at home order, which is really what we're operating under right now. But you can apply to move to the think it's called the Protect Your Neighbor status, which has some real different limitations on it, but there's certain criteria you have to meet in order to do that. Unfortunately, what we're seeing locally, and we didn't, this is not really a big surprise because we expected with a lot of the reopening and especially a lot of the activity that's going on in the area with the tourists coming in, that we'd start to see some increases, and that definitely has happened during the month of July. So we've been, one of the things we have to meet, a criteria that we have to meet is a percentage of positives. They track what your percentage of positives are over a 2-week period. And they also track what is the number of positives per 100,000. Obviously, we don't have 100,000, but you extrapolate what our rate is based on our population. So in the month of July, if you follow those 2-week periods, rolling 2-week periods, at July 6th, we had a positive rate of 1.3%. The following week, for that 2-week period, it was a 1.8. The next time it went to 2.7, and just ending on July 27th, we went to 3.5% on our positive rate. And if you look at cases for based on the 100,000, that translates into 22 on July 6th, 41 on the 13th, 68 on the 20th, and we just finished up at 75. And you have to be below 50 in order to qualify to move to that next level. And obviously we don't do that right now. So we'll continue to watch that. It's been interesting is that the guidance that the county is getting, and as we work through this plan, and why it's important is that they're being told, and we're being told, that you can plan on staying under this type of environment for 18 to 30 months, which is not good to hear from anyone, I hear at this point. But I think the reality is we're going to be stuck in this until there's a vaccine. I mean, that's really what the reality of it is, until something happens along those lines. But just wanted to give you a little bit of update on that. Obviously, from our standpoint, we're not really changing anything internally. Our requirements to protect our staff, our patients, are continuing as they have all along. So we'll continue to work through that. Any questions on anything along those lines?
I don't have any.
Okay. Just want to give you a little bit of an update. This happened after the last board meeting. Right before the SHS board meeting, we learned of a possibility of getting a DOLA grant of $150,000 that had to go through the MCHD. We learned of this about 4 hours before the deadline, and big thank you out to Bridget for coordinating, and Rick to working on that to get everything coordinated, and Dean jumped in and got some papers signed so we could get it all submitted. And I believe at this point we have been approved. Is that true, Bridget?
That's correct. We've been approved, and as long as what we submit for reimbursement meets the COVID-19 guidelines, we should be good to go.
Right. It'll basically run through MCHD, and then they would reimburse us. It's basically the way it would work. So that was a unexpected event, and obviously a good one from that standpoint. We really don't have a lot else. We're going to talk about some things in executive session, a lot about some strategic planning, things along those lines a little bit later. But right now, unless anybody has any questions for me, that's about it right now.
So Tony, what was the DOLA grant for?
COVID expenses.
Okay.
Yeah.
Basically, we were approved up to $150,000, and we can submit expense-related items up to that 150. And we're ensuring that we're not double dipping in some of the other buckets, such as stimulus money, such as PPP, and things like that. So we have not submitted anything as of yet, but it is out there if we need it.
I suspect we will be submitting something if that's available, huh?
Probably will, yes.
Yeah. Okay. Okay, anything else for Tony? All right, let's see. We do need to approve some minutes. If there's nothing else for Tony, we do need to approve some minutes. The June regular meeting minutes. Do I hear a motion for that?
I so move.
Okay, there's a second.
I second.
All right, all those in favor?
Aye.
Okay, any
Aye.
opposed?
I guess.
I guess, all right. Sounds like none are opposed. Okay. I think we're gonna return or adjourn into executive session. Do people need a 5-minute break or so before we do that?
Yes.
Take a quick break.
Yes.
For those who are leaving us via YouTube, we appreciate you joining us. I know it's not the best way to follow this meeting, but it is the situation that we're in. Certainly, if you have any questions, you can reach out to Tony or me. And again, if there's anybody from the hospital that's joined us on YouTube, please let it be known that we appreciate all the hard work that you all are putting in at this point. And the dedication and your determination is why we're successful at this point. So thanks to all the hospital staff that may have been joining us today. Other than that, let's take 5 minutes. Karen and Carrie and Travis, thanks for joining us. And we'll come back in about 5 minutes. I want to adjourn